Hi, everyone. Welcome to another Nechama Comfort Insta Live. I am so excited and grateful to invite you here tonight. We're going to have an amazing conversation with Dr. Jonathan Ratzersdorfer, a wonderful OBGYN in New Jersey, but he is here to answer all of your questions all over the world, to really give us an insight what the doctor feels, what you want the doctor to know. So I'm going to invite him on. And if you have any questions you want to ask, I know some of you have, and we will try to get to them. So I've invited Yoni, as I know him as, on. And I look up, there he is.
Oh,
There he is. Around the corner, and on my Insta Live. So I just told everybody I gave you this big build up because we're so excited to have you here today.
thank you. Thank you.
So welcome, Dr. Ratzersdorfer. As I said, I know you as Yoni. I know many of your wonderful, blessed patients know you as
Yes,
Jonathan, Dr. Ratzersdorfer. So welcome here. We're just so privileged to have you here. I think this is the first time we're actually inviting an OBGYN, a medical professional, to share your insight, to thank you to giving us the time. People have sent in questions. I told them if they have anything they want to put on the chat
excellent.
that we could find out. And I'm very picky with my case managers. As some of you may say, that name sounds familiar. Sharon, Gioni's mom, has been a dedicated case manager of Nechama Comfort, always there to help. And that besides that, I think you're an amazing doctor, even though we followed your career from the beginning. I really am. So we're privileged to have you here tonight. Welcome.
Thank you.
And,
I'm so happy to be here for you guys.
oh, you're amazing, amazing. So let's begin. Tell us about who you are.
My name is Yoni Ratzersdorfer. Like Reva said, we've known each other a very, very long time. I grew up in the same community. Ultimately, med school, I went to med school in Newark at UMDNJ. I then went to Pittsburgh for residency to a very big women's hospital, and then returned to the area basically to continue practicing. So we brought our family back here to Bergen County, and I've been here now almost 10 years in this practice. And we have a unique practice, as many people have heard about us. And so we really cater to this population of people who have suffered losses of various types. And so I've worked a lot with Reva over the years, and people have reached out to us. We reached out to Nechama Comfort. It goes in both directions, oftentimes.
Yeah, wow, it's 10 years already.
Yeah.
Amazing. Wow, I remember you were in Pittsburgh. So can you share with us, people are coming on from all over the world, and I'm watching another Insta Live. Did we lose you? I don't know why he left. Uh, let's see what happened. I'm going to invite him back. I don't know. Let's see. I'll have to go.
Oh, sorry about that. I don't know what happened there.
I know. I was just going to come knock at your door if it didn't come back on. Um, so, like I said, there's so many people. We work with families all around the world. Not everybody could be close enough, but I want them to hear about your practice. I want you to be a little bit detailed about, first of all, what made you go into obstetrics, gynecology?
Always the famous
Yes.
question: Why would you want to be an OB? There are a lot of issues, and reasons that it happened. In med school, obviously in third year of med school, you do rotations in lots of different fields, and everything was really nothing spoke to me. Everything was dreary and sad and things like that. And got to OB, and I totally just loved it. Fell in love with it. The whole process of pregnancy, babies being born, was really a tremendous process. Obviously, the vast majority of the time, a very happy process. Of course, as unfortunately this group well knows, doesn't always go that way. But I also felt in those moments than situations that I dealt with, which unfortunately are way more often than people think. I really felt weirdly comfortable in those situations, trying to help people through that process. And through my training time, I trained, thank God, with some really, really wonderful people and really learned a lot about it. And so the vast majority of the time is happy. There's medicine, there's surgery, there's all the standard things you hear about OBGYN. But this piece of it actually did really speak to me in a way. And unfortunately, I have a lot of practice dealing with the situations. And so it kind of just grew naturally.
Well, thank God and thank you. Did so your practice, who do you focus on? Who comes to your practice? How many doctors are in your practice?
So we're a group of 4 doctors and 3 midwives. We also have some wonderful physician assistants, nurse practitioners, in the practice as well. So we're, I would say, a small to medium-sized group in that sense. We're not a solo practice where you just have one doctor and that's it. But we're not some huge group where there's 10 doctors, 20 doctors. We're cross-covering with other groups all the time. We are sort of a boutique type group where we are on call for ourselves all the time, with very, very few exceptions, being like Yom Kippur. But that's pretty much it. So we're always there for our patients. We're there 24/7. We see patients very, very frequently, typically. We are very on top of things. We don't like surprises. We like to really be on top of things. We see patients frequently, and we also provide things in a little bit different model. Rather than your standard prenatal care where you go in, you get a blood pressure check, talk to the doctor for 4 seconds, they measure your belly, and you walk out. We do ultrasounds at every visit. We do everything in our own office. We do all the blood work, everything in our own office. We are rarely sending patients running around all over the place for things. So in a way, it's really an integrated process where we try to do everything A to Z and cover all our bases.
So would you call yourself a high risk practice?
Yeah, we are. So we have patients of all varieties. We certainly have plenty of low risk patients who come to us, sort of your standard routine OB patient, which of course you never know how a pregnancy is going to go. And that's sort of our whole idea and our whole model is that while many people think they're quote unquote low risk, you don't actually know
Right.
until you hopefully have that baby at the end of the pregnancy. But we definitely have a lot of high risk patients, patients with all kinds of medical complications. People have had very difficult deliveries in the past. We do a lot of VBACs, so vaginal births after cesareans. We do breech deliveries sometimes, twin vaginal deliveries. So it really depends on people's scenarios, people with medical issues, diabetes, blood pressure issues, et cetera, et cetera.
Yeah, I know the term high risk is more of a recent term. I was going through my pregnancies, my losses. There wasn't anything really high risk. The word fertility specialist, it was just everybody going to your doctor. Now it seems that there's so many more high risk doctors sending you to first you go to your fertility specialist and then you go to your doctor, or do you have a normal pregnancy or pregnancy loss? So it's great to hear that really you're welcoming everybody.
Yes, we
So
are. We are
yeah.
often the port of last call for a lot of people. They've tried everybody else, and people say no this, no that. People come to us, and we give them what we think is a fair opinion of things, and we're happy to take people through the process as long as we think it's safe and reasonable.
So if somebody knows beforehand, because so many things we can find out now before we even try to have children, that they have an issue with fertility, would they come to a regular OB first? Do you go then, or do you go right away to a fertility specialist?
Different people do different things. I mean, most people hopefully are following with a regular OB, anyway, for sort of their routine annual care. And so if you've been thinking about pregnancy and you're planning to start trying, that's always a good conversation to have in terms of trying to maximize your health situation, nutrition, diet, exercise, et cetera, prior to trying to conceive. And if you're having issues, then that's definitely something to bring up. General OBGYN can definitely start the workup and potentially treatment process. Certainly in the New York area, there's a very quick jump to fertility doctors, which I don't necessarily think is a problem. I think it's a good thing very often. This way, you're getting the treatment that you need, the workup and treatment that you need, really in one setting, not sort of a piecemeal process.
So somebody in your practice would work parallel to a fertility doctor?
Correct. We don't do fertility treatment. So we see people prior to pregnancy if they have, let's say, medical issues, pregnancy complications in the past, losses, et cetera, they want to discuss. Should I get pregnant? Should I not get pregnant? Is it safe? Not safe? What am I looking at? all of that sort of preconception stuff. So we do a lot of that. But we don't do fertility treatment for that. People are just coming in saying, I'm having trouble getting pregnant, and we may start the process, but really we're referring people out.
So a question that comes up, and I see the answers have changed over the years, was I've been trying, sometimes I even hear, I've been trying for 2 months, I'm not pregnant. I'm going to go to the fertility doctor.
Yes.
So what is in your medical
So
opinion should be the time that somebody should be concerned?
yeah,
I know in my day it was a year. If you didn't get pregnant, a year. Now I get calls. I can't believe how much. I was just at their wedding,
right.
calling and they're worried already.
Yes, there's definitely a lot of psychological stuff, that's in there. There's definitely a lot of community pressure that people
Yeah,
feel and that sort of thing. People think you get pregnant you think about getting pregnant, you get pregnant. The
right.
reality is humans are not good at reproducing. The odds of a healthy couple who has no fertility issue getting pregnant in any given month is only 25%. So we're not actually that efficient at reproducing. Now, most pregnancies will happen within the first 6 months of trying. So if there's an obvious problem, for example, a woman's not having regular periods, then there's no point in trying for a year endlessly. It's not going to happen most likely. So if there's no obvious issue going on and someone's not too old, you're under 35, then really trying for about a year makes sense. If one's older or there's an obvious problem that can be looked at, then a couple of months. People usually will try 3, 4, or 6 months, and then there's an obvious problem. Move on.
Wow. Did everyone hear that? He said a year, to try a year. I know it's just
Depending on age
right,
and other, but
right.
yes,
Oh, so now that you brought up a lot of things that people sent in to ask. So talking about
yes,
age, have the numbers changed? I know it used to be 35. If you were 32, you were getting to the clock was ticking.
yeah. So age is a very tricky thing. It also depends on what we're talking about, right? So first issue is just getting pregnant.
Right.
So even at 30, if you look at graphs, there's fertility rates are starting to decrease already, even at 30, and it does accelerate as one gets to their later 30s, over 40, etc. So that is definitely something. That being said, someone turns 29 and a half, they don't need to be banging on the door of the fertility office.
Right.
My eggs are growing. So there's definitely that piece of it. In terms of other issues with age, risk of miscarriage is higher as one gets older. The risk of syndromes, Down syndrome, etc., is higher as people get older. So birth defects. So these things are there; they're real. These are all things obviously can be tested, or most things can be tested during pregnancy. So that's all a piece of it. 35 is a little bit historic. Why that's considered the age really over 40 is where we start to talk a lot more about issues with pregnancy.
And of course, that's talked about now, at least in our community, a lot in different ways, is egg freezing. People have this. On one hand, it's great that we could 40 now come the age, but people, I think it's also an amazing thing that medical technology is so advanced. But I think people are thinking, because you're so advanced, if I just freeze the eggs, we'll take them out, we'll get pregnant, or we could just go for fertility treatments and just get pregnant. So I don't know what you've seen in your
It's
practice.
definitely giving people, I think it's definitely giving people a false sense of security. The number of eggs that one needs to get in order to really have a good odds of a pregnancy is higher than most people think. The other issue that really comes up is pregnancy when you're 43 is not the same as pregnancy when you're 23 or 33. There are more medical complications that happen, more preterm deliveries, preeclampsia, etc. That does come up. Yes, it's a wonderful technology. Certainly for someone who has cancer or something like that, it's phenomenal. Obviously, I would encourage people. If someone is saying, "Listen, I'm not ready to have a baby yet. Should I freeze my eggs?" I mean, sure, it's there and it's definitely beneficial. But I don't think that everyone should just be running to egg freezing. And the other piece is that I think people that have not gone through IVF don't realize that IVF is a big deal. It is a very difficult process for a lot of people, not always well tolerated. It's a big process to go through for people.
Right, right. And, unfortunately, or fortunately, I say, our community, the Nechama Comfort Pregnancy Loss community, has grown. It's grown because the stigma in many places has lessened, not gone away, and also because we know so much earlier that we're pregnant, the attachment is there, and all of the genetic testing. So I wanted to get into that a little bit from a doctor's point of view. So a couple uh, typical couple comes and they're pregnant. And nothing unusual. They're not coming with anything unusual.
Mhm.
And do you, when you have that first meeting with them, is it mentioned at all that things can go wrong? You know, it's such a balance. I know when people want, they don't talk about the topic. When you go to your premarital class, they don't want to mention it. We don't want to talk about bad
Right.
or superstitious. As a doctor, a couple comes to you and talks about, um, well, I'll take a step back. Do women ever come before they start trying, or when they first, let's say, get married, or is the first time you're seeing them when they're pregnant? Is there ever what do
I
you
usually see people when they're already pregnant.
uh-huh,
You know,
right. People don't necessarily come,
not not to us that
right,
much.
right,
Not to us that much. Not in our group.
right,
Our
right.
group, most of the time, people are already pregnant or think they're pregnant. You know, they may be very, very early and not sure, having an issue. Bleeding in early pregnancy. That sort of thing. And we're sort of sorting out what's going on. But we don't see too many people. Just I got married. I want to get pregnant. We don't see that much of.
So a lot of couples when they after their losses will say nobody told us that this could happen. I'm not saying that's right. You're
Yeah.
not saying that's right or wrong, but it's definitely something to talk about.
Yeah.
It's definitely.
I think
And
early
by the way, do you
miscarriages.
talk about it in your first
Yeah.
meeting?
I think when you see somebody, I see somebody who's 6, 7, 8 weeks. It's a very common question. Patients bring it up all the time. Should I start telling my family? What's the chances I have a miscarriage at this point? That sort of stuff. That comes up all the time. I often will throw into that, conversation something along the lines of, until the baby's out, we can never guarantee anything. It's obviously very uncommon to have third trimester losses. And so most people, it's not front and center on their mind. Although we do have patients that they've had family members or friends or something like that, have had losses, and so it's front and center on their mind, and they bring it up all the time.
Right.
But I tend to sort of slide it in there early on, if it comes up. I don't specifically go out of my way to tell someone, oh, and by the way, you could have a third trimester loss
Right.
in only 7 weeks.
Right. But the same with miscarriage. Do you mention that to them
Uh,
or?
that almost always comes up.
Uh-huh.
That almost always comes
Right.
up.
Okay. So we hindsight is foresight. I always tell the couple too. Why would they have told you that, and what would you think about that?
Right.
So
To tell someone at 6 weeks, by the way, the baby could die at any time, is not
exactly.
going to help somebody with their pregnancy.
Right. Right. I agree. And so let's say you do have the couple comes in. Um, Even before that, are there genetic tests now that you are requiring that is changing?
Require anything.
Uh-huh.
We counsel patients on all of their options. We offer. I mean, we as a group, do think genetic testing is a good idea. Certainly with the cell-free DNA and that sort of stuff. Without necessarily having to stick a needle into someone's uterus.
Right.
Amnio is offered to everybody. That's the standard of care, is to offer amnios. Putting a needle in to get fluid from around the baby is the standard to offer it. Most patients don't go for it right off the bat.
Right.
Uh, but we do encourage and we counsel all patients about genetic testing. We also have a genetic counselor on staff who we offer to all of our patients to have a consult with early on in pregnancy so they can understand what all their testing options are, which again
Do
is
you, yeah,
unique. Most practices don't
yeah,
have that.
that's amazing in your practice.
Yeah.
Wow. And do you find that there's been an increase of couples coming to you who have already had the testing and have gone
Yeah.
through genetic testing?
Yeah, a lot of times people have had, earlier on, whether, before marriage, whether with Dr. Sharm or some other, lab, they've had carrier testing for autosomal recessive diseases. When patients come to us later in pregnancy, they've often had Down syndrome testing, done at 10, 12 weeks.
So they've already gone through that.
Oftentimes.
So let's touch base uh, with more specific questions for this community. Um, an early miscarriage, most people, they see spotting, they're having cramping, they reach out to you, right? They'll say, let's say 7, 8, 9 weeks. What, as a doctor, how do you, the couple obviously comes in, you get that call.
Hmm.
Uh, and you can't represent all doctors, only the good ones. What would be your recommendation for doctors for to tell how do you tell that patient? How do you treat that loss?
I tell someone that they've had a loss.
That they've had a loss early
Yeah.
on, because there's a early on in their
I mean, I think most oftentimes, by the time I'm seeing the patient, at least the way our office functions, they've had an ultrasound, and so they often already have, an inkling that something is going on.
right,
The way we do it, since like I said, we do ultrasounds every visit, we bring the patients into our ultrasound room, and the sonographer will come get one of us and say, yeah, it looks like a miscarriage, can you come in? So we don't just send that patient back to the waiting room, to just go sit there with all the other patients. We,
right.
we will go into the room, tell them, briefly break the news, unfortunately to them, and then try to bring them straight into the room where we sit with patients to talk, which we sit sort of across a desk from people with, regular chairs. You don't see people on exam tables or undressed or whatever. We see people fully dressed in sort of a consult room, as how we do all of our visits, and then we take people to an exam room if necessary for an exam. So we try to bring them straight in to talk to us and carry on that conversation.
Can you share with us what you say to that couple?
I mean, I sort of, I guess, wing it each time in a way because every situation is different. Uh,
Right.
but I'll go into the ultrasound room, and oftentimes sometimes the patient clearly already knows what's going on. But as I'll say, they have unfortunately really bad news, but we don't see a heartbeat, even though it's really really early. We saw one last week or 2 weeks ago, whatever it was. I'll obviously have quickly looked at the chart before going in to see what where we stand, and where the patient was at the last visit, and then if people want a second look, on the ultrasound, if they didn't realize, no problem, lay them back down, do that, and then sort of tell them, take a moment, we'll step out, take a moment when you're ready. You come in, I'll be right next door. You come in, and we'll carry on the conversation. Sometimes people take 10 seconds and they're with me. Sometimes it's a couple of minutes before someone's ready. They may stop at the bathroom or something like that. I always put the tissue box, right easily within their reach before they get in the room. This way it's there and it's obvious, in case they need it. And then we carry on that conversation where I try to explain to people how obviously it's nothing that they did, sort of that sort of, piece. And I was will often throw in there at some point also to patients, while going through all the stuff, that trying to be as encouraging as possible, because that's often what people are looking for, that there's nothing they did, but also, I know that you're not really necessarily hearing everything I'm saying right now, and that's okay. You're not believing me that, next pregnancy, you're much more likely to have a successful pregnancy, because statistically, someone has one loss, they're much more likely to have a successful pregnancy the next
Right.
time. Of course, many people, their mind jumps, straight to that. Certainly if it's a first pregnancy, will I ever have a baby? Will this ever work? All of that stuff that comes along with that. And unfortunately, we see that a lot, trying to be, upbeat in that way. But after a few minutes, trying to shift the conversation to what our next options are. Genetic testing, is it worthwhile, is it not worthwhile, does somebody want to do it, not want to do it? Management, and I always tell people also, unless you start hemorrhaging or have an infection, there's no emergency. So you can go home and think about it, speak to your partner. If they decide right at the moment what they want to do in terms of managing an early miscarriage, great, we start that process. And if they want time, no problem. They're on
Well,
call back.
we get calls now more, and we don't give medical at all. So the questions they always ask is, the doctor came in and said to us, do we want a DNC, or if it's a later GNE, do we want to go natural? Do we want to take a pill? What do we want to do?
Yes.
Um,
So one of the important things I learned in during residency and during training was, obviously nowadays, right, we no longer live in the world of doctors just telling patients what to do,
right,
right? It's all about giving patients their options. But one of the key things that I had learned really along the way was directed counseling, right? If something is not a good idea, don't necessarily tell somebody, yeah, here you go, just sure, A, B, or C, which one do you want? If something's not an option, it's not an option. So if someone is 20 weeks, you're not going to talk to them about taking, the pill, to get it over with in a couple of hours. That's not where you're at in the pregnancy. So I try to speak to patients about all three options: waiting, the pill, DNC, pros, cons, the what's quicker, what has higher rates of complications. And then, yes, sometimes you get the dreaded, well, what would you do if it was your wife,
oh
question.
yeah,
That's always a tough one, but I try to be honest and tell people what I feel. at least what I would do. But again, I tell people that's not what you have to do. And sometimes I'll tell people, listen, this is your odds of success. This is the way to look at it. And I also explain to people, everyone looks at numbers differently, right? So let's say something has a 10% or 20% failure rate. Well, that means it has an 80, 90% success rate. So some people look at the failure rate, some people look at the success rate. Everybody's different how they view that. And so I explain to people, there's not a right or a wrong in that. Everyone looks at numbers differently.
Right.
And when I leave it with people, very often they're not sure yet what they want to do. So I leave it with them as go home, and you can always try expectant management, basically waiting for your body to do it on its own for a little while. Call us back in a week, and if it hasn't happened in a week, then we can, or 2 weeks or whatever time frame the patient wants. We talk about the risks and the pros and cons, and they can call us back.
Wow. It's so inviting to families.
That's the
And yeah, yeah. And what about so late term, I know I don't know what's in Jersey now. 20 weeks and over is considered later loss now, stillbirth. I don't follow, I just follow the family's emotion. The attachment is there so much earlier. The sonograms, they know the gender at 9 weeks.
sure.
So when you see those, and you have to tell the family that there's no heartbeat,
Yeah, 20 weeks at the
right?
anatomy scan or later on, and so that
Or later on, 38 weeks,
that is infinitely worse. Of course, everybody, not everybody, but the vast majority of people know people who have had early miscarriages. So early miscarriage, while I explain to people, is a terrible thing to have to go through, is a normal part of reproducing. If you are going to try to have babies, you will have early miscarriages.
right?
It's just what happens. The statistics are so high. It's just what happens. For mostly, obviously, for better, the majority of women and people don't know anyone that's ever had a late loss because, thank God, it doesn't happen terribly often. And and through modern care, it happens less often than it did in the past. So most people don't know anyone it's ever happened to. So that is a much, much, much harder conversation. But in the end of the day, the conversation does sort of go the same way because ultimately it's about understanding what's going on, coming to quote unquote peace with that as much as possible in the moment to try to understand that, and then what do we do next? And we approach it the same way. Unless there's an emergency to get the baby out of somebody, we tell people you can, go home, process this. If you want to come in today, tomorrow, we will get you in as quickly as we can to whether we're going to do a labor induction or a D&E, depending on how far along we are, etc. And sometimes people want to come in right away. They just want to go to labor and delivery and get the process started. And sometimes people want a day or two. And, we talk about obviously the warning signs for emergency. And as long as there's no emergency, you let us know.
Right. Well, but how far you don't let them go so long, like your
No,
entire
no, we're not going to. I mean, if we know that the baby's not alive and you're
right,
37, we're going to tell you to walk around for 2 weeks.
right,
Um, but if there's not an emergency, you don't have to come in and be delivered that day. If you want to go home, gather your things, you have other kids at home, get things situated, you want to come in the next day or something until you wrap your head around the process and all of that. Sure.
and I think the majority what I hear with our families is that most of them deliver naturally. That most
Yeah,
doctors
and certainly,
encourage not to do a C-section, not to
correct, correct, correct.
right,
Yeah, you generally want to try to avoid C-sections if the baby's not alive. Sometimes you have to, you don't have a choice
right,
based on some history. But generally speaking, you want to avoid it just because there's no benefit for the baby, obviously, at that point. It's not like doing a section to save a baby or something like that.
right,
And so there has to be only benefit for mom, basically, which would be based on her history.
right. So we say, if people say, we tell them it is better. It's better. It's emotionally, it's much better to deliver the baby and to see the baby and have that experience. And it is an easier recovery physically
Sure.
than having to recover for the C-section.
Sure. But at the same time, if a patient, you speak to a patient, like everything in medicine, you
Right,
can a patient, they understand the pros and cons, and somebody absolutely insisted on it, sure.
right.
But generally speaking, unless there's some other complicating factor, which happens every now and then, generally labor induction and vaginal delivery is the way to go.
So, do you or your team, um, after the baby's delivered,
Hmm.
and they go through the emotional, trauma of delivering the baby. Is your practice of the doctors, midwives, are they involved afterwards to make sure? I know you're in a few hospitals, right? You're in three
We're a
hospitals.
sec. We're at
We're at
Hackensack.
Hackensack.
Yeah.
Um, and and they have an excellent team. They have an excellent bereavement
They're
team.
very good.
But are you're making sure that that's all taken care of too?
Yeah, so if let's say somebody's going to come in for a labor induction, for a late loss, if I'm the person admitting someone in that situation, I sit with them for a very, very, very long time, just before we even do anything, just to understand where they're at, because I didn't necessarily see them in the office or make the diagnosis. So, understanding where they're at, understanding medically where things stand, emotionally where they're at, and trying to talk through all of these various things. So I tell people, so for example, like what you were talking about, do people want to see the baby, hold the baby, or do people not want to? Sometimes one parent will want one thing and the other parent will want the other thing. You may have a situation where mom wants to see and hold the baby and dad doesn't want to be anywhere near it. In which case we can make that happen, or
Right.
the reverse. Unfortunately, I've done this a lot of times, and so I've seen every variety. And I try to tell people that every response is normal. There's no such thing as what's normal and
Right.
not normal. Everything is whatever is good for you. And I also tell people that you might think one thing now and something different in a few hours. Even after the baby's born, you can change your mind at any point. It doesn't matter. It's a fluid situation. I sit with people even from the get-go and try to explain the labor process, the induction process. Um, we try to talk about some of just the paperwork issues that are going to be necessary in terms of death certificate paperwork, autopsy paperwork, trying to get as much out of the way as we can. For funeral home arrangements, at least to put these things on people's minds so that they, know where they're at in the process. But I tend to sit with people for a very, very long time, talking about pain control, if someone, what they might want for pain control as time goes. And it's not necessarily the same as, when you're delivering a full-term live baby. So things can be handled a little bit differently. That also, especially if it's an earlier loss, in the second trimester, sometimes deliveries happen very, very fast.
Right.
And so you may not even have someone in the room with you. You may not have a doctor or a nurse, because sometimes from the time you feel that the baby's coming, you hit the call bell, the baby comes out. That doesn't obviously happen at 38 weeks, but if you have 20,
Right.
20 situations, that can happen. So I try to prep people that can happen, just so that they're not scared if it happens, because I've had that happen to patients and they're terrified,
In the
obviously.
hospital. Yeah.
They're in the hospital. They're in the hospital.
Right.
They're
And
everything
they're waiting.
normal, and it's just from the sometimes, because the babies are so small at that stage. From the
Right.
time you feel something, the baby just plops right out. Especially if you have an epidural, you may not feel much till the very, very last second. You hit that nurse call bell, and the baby just comes right out. But I try to tell people it's scary, but it's actually a good thing, because that means things are going okay. It will be in the room, very, very quickly, and and deal with whatever's going on. But I think if you warn people and give them the heads up, it's not as scary then.
Yeah, and we also been getting a lot more, I think over the last year or so, calls from couples that want to bury the baby,
Yeah.
even in the earlier stages. And and I think a doctor like you, who is on top of things, would be there. Like if a case like that happened, if they delivered, if they're in the emergency room, or something so quick
It
that
can be
they
very
understand.
tricky. It can be tricky. Because the way it works is that, or at least the way they do it at Hackensack, over 20 weeks or under 20 weeks is the dividing line.
Right.
Um, right. And so over 20 weeks it becomes funeral home and, and morgue, whereas
Right.
after that it's pathology. And so it's a bit of a different process.
Right.
Obviously, pathology is not as familiar with sending things for burial. So it is always a runaround when those kinds of things come up. But we try to do what we can to help the process if that's what
Yeah.
somebody wants.
And if the couple calls us before and we say you definitely make sure that you tell the staff
Yeah, you have
that
to
you
see
want,
from the get-go
right,
if
that you want to do that. But
yeah,
we definitely see an increase in that.
yeah, if you're having 10-week DNC, you have to say so from the get-go, or it'll be very challenging.
Yeah.
Yeah,
I know of couples recently, somebody took it home by themselves and then we can't get the certificate, but
right.
we work it out at Nechama Comfort.
Yeah,
We figure a way.
exactly.
Because I think the attachment is there so much sooner. So I think
Sure.
if the doctors like you would recognize that, I think that would help. And then following up,
Yeah.
does your office reach out to the couple?
So we do. I mean, we tend to. With early miscarriages, things are sort of one way. When someone has a late loss, obviously, then they're going to come in for a postpartum visit. Routine. The way that any pregnancy would go.
Right.
And we'll have people come in sooner. We really, if necessary, we really try to feel it out with the patient. And I leave these situations. I very much leave to the patient's direction. I say to somebody, obviously from a medical standpoint, we'll do whatever's necessary. Someone has to be in a couple days because there's an issue, worried about
Right.
something, certainly. But putting that aside, anytime when it comes to sort of the emotional pieces, I'll say to somebody, if you want to come in a week to chat, no problem. You want to come in 6 weeks, no problem. We'll follow your lead. Early pregnancy losses, someone had a DNC. I don't make people come in for follow up because if everything's, we talk about what to anticipate for recovery, let's say from a DNC or an early miscarriage. If
Right.
everything as planned, usually I'll have a phone call, and if everything's good, no reason you need to schlep into the office. But if you want to come in, to talk about it or whatever, no problem. We'll set a time, we'll make an appointment for you to come in. At least at Hackensack, genetics testing usually takes about
Yeah.
3 weeks. So,
Yeah.
we always tell people if they're sending genetics, we will call you when the results come back, to go over results. And if they want to come in for a conversation, sure. If they want to do it over the phone, we'll follow their lead.
And pregnancy after loss, which is
Yeah.
huge. Not just the first pregnancy, but the
Every pregnancy,
every
sure.
pregnancy after loss. We have our own support group for that.
Yep.
Because so when a couple comes in, either they've been with you for the first loss or looking for a better.
We get a lot of people coming to us after a prior loss somewhere else, and they're coming, and they come to us at that point.
Well, we recommend you a lot, but I can't do any endorsements live. But yes, yes, um, right. So obviously, you're going to give them. Well, what do you
So,
give them extra? We tell them what to ask the doctor.
right. So right from the get-go, we give them a lot of time, right? As soon as we get that history and we know that that's in there, even if someone is 6 weeks and they had a 38-week loss, we
Right.
try to, understand everything that occurred, try and, do we have an explanation? Do we not have an explanation? All of that. Obviously, if there's an obvious explanation, is there something that can be done about it differently, going forward for this pregnancy? Unfortunately, oftentimes there's nothing that, can necessarily be done differently. But, monitoring, potentially, although oftentimes, again, statistically, we know it doesn't really make a difference, but it makes people feel better. And so I tell people, you want to come, we'll tell you how often you have to be here from a strictly medical standpoint. And then I have patients who are like, yep, I'll do that. I'll be here as little as possible because I have too much anxiety coming in. And no thanks, I don't really want to be here every week, even though, some people like that better. That doesn't work for me. And unless there's a real medical reason they need to be, I don't tell them they have to. And there are people who want to come in every week. And I've had patients come in every single week from the time that they, had a positive pregnancy test and we saw something ultrasound at 6 weeks until they delivered all the way at the end. And we see them every week. And then sometimes at some point they decide they want to come in twice a week and they're coming in twice a week. So I really tell people we'll tell you what we need and then we'll follow your lead outside of that.
Wow. Amazing. That's what people want. That's what people want. They need. And and I'm sure it's difficult for you, you know, to process this. How do you deal with that? How do you deal?
I mean,
You have a lot of joy in your life and
yeah.
joy in your work,
I mean,
and
look,
then
every baby obviously is special, and it's wonderful delivering babies. But especially if I've been through a loss with somebody, and then deliver their next baby or some baby down the road from that, that's it's just that much better. It's that much extra special, because you've been through such terrible things with a family, and then to be able to be there on the other side of it when when they've and certainly if they've had no children before, and now this is their first baby, it's that much more special for people, and it's that much more exciting.
right, and to be and your sensitivity, I think, probably to your own family and children
Oh
and
yeah.
community comes
Right.
comes from that.
Yep.
And as we have more also a big increase in male clients over the years. We have our own male support group. We
Oh,
have case
good.
managers. As a doctor, as a male doctor, do you find that the husbands are reaching out to you more, that the partners are reaching out to you more?
I certainly
There,
I know the couple, like I know them, from their loss. I will often ask, if the husbands are not there at the earlier visits, I will often ask their wives how they're doing. Because we all know that men are often not going to talk about it, and
right?
oftentimes they handle it worse than their wives do. And so, trying to find resources for them is really important. I didn't realize you had a male group, so that's really good to know.
Yeah, we have a male group too. We're there to help even grandparents, other children, other siblings, because everybody's involved.
Yes,
Somebody else want to ask the question because you talked about midwives.
yes.
So more about are there more holistic approaches now with fertility journeys? Is there any, do you do anything that's not non-medical, but in a different holistic view? Um, and
So
also, yeah, in terms
yeah.
of midwives,
Mhm.
how does that work?
So we try to really, like we said, earlier, we try to really offer, A to Z. So, we have midwives who, have the more, that sort of that more bent. That being said, we are a high risk practice. And so we have a lot of patients who have, a lot of issues. And so we will, like I said, we often follow the patient's leads, but at least in our practice, it's not going to be, totally, crunchy granola all the time, because that's just not our clientele most of the time. But yes, if we have, patients who are in that, want to go in that direction, we're there for that. That's totally fine. But yes, all the time we're getting questions, vitamins, diets, exercise, all this kind of stuff. We try to cover, all those bases, with people.
So, what do you think has been, hopefully for the positive, the biggest change as you've seen it over the last 10 years, dealing with families with pregnancy and flaws from a medical standpoint? I was actually just at an engagement party a few hours ago. So, sometimes I feel like a doctor or a lawyer, and somebody asked me what they're doing, and somebody said, "Oh, I have a friend's daughter was a grandmother. Um, it's because she thinks it's because of the COVID shot, right?" And I said, "Well, when was the loss?" And she said, "A month ago." I said, "When did she get her COVID shot?" 5 years
Right.
ago.
Yeah,
So,
probably unrelated.
um, so have you seen, you know, the statistics I think are the same, right? 1 in 4 miscarriage, 1 in 8
Yeah,
stillbirths.
I mean,
What?
there's the issue of, like we were talking about age earlier, right? People are older, people are less healthy, having pregnancies than they were 30 and 40 years ago. So
Right.
that's definitely an issue that we're seeing and we're facing, leading to issues. I think the biggest thing, that's been positive in this way is really just more education out there. That's really been the biggest thing. Groups like Nefama Comfort, but also in the hospitals. The nurses get more training. Residents get more training in pregnancy loss. I think that's really been the biggest thing is people really just learning, seeing the whole picture. Much better support and that kind of stuff. From a medical standpoint, unfortunately there hasn't been that much, improvement over time. Infections and high blood pressure and all the various things that have been the traditional causes of losses are still there, and we unfortunately have not made great strides in a lot of it. That's the way it is, till now. But I think the biggest thing that I've seen positively, over the last bunch of years is really the education. Certainly in the Jewish community, a lot less stigma about it and a lot more openness and talking. Family histories being discussed. That people were adults, they never even knew that their mom had some weight loss or whatever. And that I think is a big issue because all of a sudden so it happens to somebody and then their mother suddenly says, "Oh, this happened to me," and here's how you can deal with it and all of that. And had someone known that earlier, it might have been a little bit more straightforward kind of thing.
I definitely think couples are more educated, um, in general, like you said, exactly, and that they feeling comfortable because they're learning about the things. And there should be doctors and practices like you that are understanding, that are warm and inviting. Um, I I I hope maybe we can get the entire medical team to listen to this. It's a lot to listen to you because um, I think the most important thing that our clients want is honesty, is
Yeah,
to be understood, and for them to say, um, we get it, and to be able to feel comfortable enough to say, is it my fault? Was it your fault? Whose fault? And and I think because they can get a lot more questions answered. I mean, to me, it's fascinating what they could find out now beforehand.
sure.
I don't know if you've seen it increase. We have with medical terminations, and people having that choice to where before the babies were born, like
Yeah,
so.
certainly. I mean, we as a group are very honest. We tell it like it is, and obviously you always want to try to have positive bent on things, but in the end of the day, we tell it like it is, and we're just we're honest with patients, and we try to give people the time that they need. I can't tell you how many times I've seen patients, certainly early in pregnancy and stuff like that, and they're like, "Wow, I've never actually spent this much time with a doctor before." In like their whole life, I've probably spent more time with them than they've cumulatively spent time with a doctor. just hearing them out, trying to talk through, their issues, their questions, and all of that. So, unfortunately, the way medical care is in this country, it's not the way it is most of the time. But that's
Right.
that's what we're trying to do. We're trying to do things differently and hope in the way we think they should be done to treat
Wonderful.
people.
So for anybody that's lucky enough to live in the tri-state area, so tell us where your practices are.
We have offices in Hackensack, one near Lakewood, Hoboken, and Jersey City. So we have 4 offices
And,
all over Jersey.
and you deliver in
We deliver in Hackensack, and you don't have to live in the tri-state area. We have patients coming from all over the place.
Really?
Yep.
How far away?
The farthest thing we've had is Africa.
Really?
Really, really. I've had patients come from Africa specifically to see us. Yes.
And you could continue with them for 9 months?
Yeah, sometimes they come back and forth. They stay here. It depends. Yeah, I mean, obviously a lot of people come from Israel, which geographically is farther probably.
Wow.
A lot of people come forth from Israel. But yeah, so you get people from all over the place.
Wow. And I could definitely see why. So anybody that's joining wherever, we're going to post this so people will be seeing it all over.
Wonderful.
Thank you so much.
Yep.
It's
Pleasure.
your mom when she started working, she would always say, "I have to talk to Yodi. I have to talk to let me ask Yodi." And you were still young and going through the schooling and everything. And I remember when she told me, what you were going into. I thought, wow, that's what we need. A guy in the Jewish community who gets it. I have to give a shout out to your wife too,
Yes,
who I've
definitely.
also known forever. A T-deck couple,
Yep.
a T-deck couple
Part
who's
of
done
it.
good, and all
Yep.
your kids. And you should continue to be blessed with this.
I
And
mean,
I think this is only the first of other conversations that we'll have.
good. Let me know.
And one thing I mentioned before, we do work together, which is so important. And I think anybody listening to this, it's a team. It's a team to help these couples going through their fertility journeys.
Absolutely. It is often a multi-person, multidisciplinary team to help
Right.
you through it.
Thank you so
You're
much.
welcome. Have a good night.
You too. Bye bye.
Bye.